A MSU-COM graduate. Actually, we went to medical school together. He did his internship and residency in internal medicine at Flint Osteopathic. He did a fellowship in 1988 at Duke University Medical Center in geriatrics. He's board certified in internal medicine and geriatrics. He's been a previous speaker here at SCS. And he has been speaking in multiple other venues across Michigan and other places. So please welcome Dr. Weiss this morning, who's going to be speaking on dementia.
I'd hold my applause till after the presentation. You might not like it. You know, I look out at the tender young faces and I kind of envy you, but then I don't also. Because there'll be no Social Security for you. I think there'll be some for me and Carol. That's why I want you to keep working, right? Pay taxes, support our economy. Let's see, I've got to get this to work. The other reason I guess I don't envy you is because of this epidemic disease that you will all have to, I don't know, deal with in one form or fashion. Just coming through okay? Move the mic closer, okay? Either with your patients or with your families, as your parents, grandparents, some of you, your great-grandparents get older. Sadly, this is an epidemic disease, dementia. Let's see if we can figure this out here without the tech person. There was a tech guy in our class. No, I think I got this.
Okay, just there for forward.
There we go. All right. I might use the mouse a little bit because it doesn't show up very well. So, first of all, what is dementia? We hear this term a lot, and it's often discussed or described in the context of Alzheimer's disease, of which Alzheimer's is the predominant pathologic presentation or pathologic entity regarding dementia. Probably 70% of patients who have dementia have an Alzheimer's type dementia. So actually, like a lot of diseases and illnesses and syndromes and trivia things that you have to learn for your board questions, which once you complete them and pass them, you can forget about them because they have no reality in what you'll do for the rest of your career. There actually was a person named Alzheimer, Alois Alzheimer. He was a German psychiatrist and neuropathologist. He took care of a lady. Now, she actually died 4 years after her symptoms began. Now, that's kind of a short interval for really what is considered late-onset Alzheimer's disease, but she is the prototypical example or patient. And there was a paper that was written in 1907 after she passed away, and they did an autopsy and described what's now known as amyloid plaques and tau tangle protein accumulations. There will be no exam at the completion of my lecture, so don't worry about that. Now, the Alzheimer's brain exhibits atrophy, plaques, tangles, as does the normal brain, but in lower concentrations. Now, my wife has told me, she's a physician, so she knows everything. She's an endocrinologist, which in fact doubles the knowledge base that she has. And she says, my brain is already full of plaques, tangles, some Lewy bodies, probably some vascular disease, some inflammatory remnants, and probably some hydrocephalus. But not to the degree that I've actually forgotten who she is. So I guess that's a blessing for her and a curse for me. Not too much male bashing or female bashing today, right? All right, well, we always like the, prerequisite slide. That kind of really has no meaning to anybody, but kind of looks cool and it's kind of colorful. And that brown stuff up there is the senile plaques of what ultimately overwhelms the brain in a patient who develops clinical manifestations of Alzheimer's type dementia. So what are we actually happening? Well, there's these secretases that break amyloid precursor protein, APP, into pieces. There's actually ACE, BASE, and GACE. Kind of sounds like a rock group or something. But what happens is the gamma secretase, let's get the mouse going here because then everybody can see it, cleaves the APP in the wrong place, and then you get this A-beta particle here, which becomes insoluble, kind of plugs up your brain, kind of like some people describe it as fur balls in your brain. All right, so that's a 42 amino acid sequence, A beta particle. Some of this, hopefully through the course of this presentation, will actually make some sense and have some relevance to what you will need to consider through the course of your next 30 to 40-year career. All right. I found when I went on the internet, someone told me when I put in a word, and you can actually click a little side thing that says image, and there's all these pictures that come up. I just learned this thing. This is really cool. Some of this looks like something I've actually gotten at some restaurants with pasta in various sauces and things like that. But I kind of got this whole new world out there. Images. You guys probably know all this. See, when I was born, Tandy computer was, not even invented. You don't even know what a Tandy computer is. It's a store that was out there. All right, so this is tau protein. Now, this is the other putative agent that gums up your brain and creates havoc regarding your progressive loss or decline or inability to do the things you used to do, and your short-term memory isn't working very well. So I'm coming back now to dementia. 3 core pieces, okay? Progressive. By definition, dementias are progressive over time. Sometimes over many, many years, sometimes over short periods of time. It's a loss or decline or difficulty or inability doing the things you used to do. So when I was asked in my mental status screening, can I balance my checkbook, I said no, and they said, aha, you must be demented. And I said, but I've never balanced my checkbook. Oh, that didn't count. Okay. And then short-term memory. 50 years ago is fine. 50 minutes ago is not. So those are the 3 core pieces, all right? Along with the 3 core pieces of dementia, you will see in many patients through the course of their presentation changes in insight, judgment, personality, behavior, problem-solving skills, intellect, things that affect our lives and are part and parcel of our day-to-day activities. Where families tend to really become disturbed or distracted is when safety issues begin to intervene. All right, impaired operation of a motor vehicle, messing up your checkbook, getting fleeced or ripped off, setting the house on fire, heading out at 2 o'clock in the morning because you don't think this is your house, taking a swing at your family members because they don't recognize you. So short-term memory we can deal with. We can help keep their medications organized, functional loss. It's behavioral issues and safety issues is where everyone will be driven to distraction, both providers in trying to deal with it and family members trying to cope with it. Tau protein. So we got amyloid, all right, plaques, tau, tangles. The tau protein, the ever-present tau protein gumming up your brain. This doesn't mean much to me, but I thought it was kind of a cool slide. It's another one of those web-based images that's out there. Well, let me give you somewhat of a more different representation of the unaffected microtubule and then the Alzheimer's microtubule. And what's happening is you're getting tau proteins, but they're becoming phosphorylated and hyperphosphorylated, and then the microtubular tends to disintegrate. Now, I found another cooler picture yesterday. I thought this looked like something from the Saturday morning cartoons or something, or some creature out there. But what you're seeing here is this is what happens is these tau proteins aggregate, and they literally gum up the axon of the nerve cell, causing it to improperly function and then ultimately fail in its ability to conduct bioelectrical signals and then our brains to work properly. Okay? Is this Pick? No, this is Alois Alzheimer. This is the guy, he's a German psychiatrist and physicist. This is one of those web-based pictures. And then this is the Sentinel case. This is the woman that he took care of and then wrote the paper about. Her name is Auguste Dieter. And forgive me if my German is not that good, but she was quoted as having said, "Ich hab mich verloren." I have lost myself. That is how she described how the disease affected her. All right, now we've talked about Alzheimer's disease, but you really need to think about this as a syndrome, which gives you some broader latitude in how you will evaluate people, because there's some cookie-cutter aspect to this, to the core features, and some of the other things I mentioned about behavior, insight, judgment, personality, but there's great latitude and variation. One of the synonyms of aging is variability, not similarity, okay? So, it's an impairment in intellectual ability, multiple cognitive domains. It's progressive. We talked about short-term memory impairment plus additional cognitive disturbances. We talked about 3 key symptom domains about memory, function, activities of daily living, behavior, personality, and then what really makes everybody crazy is safety. It's the most common cause of dementia in people over age 65. Now, there are 70 causes of dementia. Now, 65 of them are other illnesses or diseases, okay? So your liver didn't work, your kidneys didn't work, you had a brain tumor, something like that. You would have some progressive decline in your ability to do your day-to-day activities, and your short-term memory would be impaired. Now, mad cow disease is also a very rare instance. Men actually cannot get mad cow disease. Does anybody know why? This is an easy question for the women. Men are pigs. Pig can't get a cow disease. Come on, we're here. Now, when I went to school here, not to pick on the school, we called it MSU, cow college. But, that's a long time ago. All right, so this is the DSM-4 criteria. This is kind of a somewhat repetition about multiple cognitive domains. But you can think about it in terms of a somewhat more concrete definition. It's problems with aphasia, speech and language generation. Now, one of the things that actually is an early presentation is expressive language dysfunction, that thingamabob, whatchamacallit, who's it's, the and then your friends will kind of fill in the blanks for you. All right, so it's articulating or understanding. It's difficulty with task performance, muscle coordination, apraxia, in the absence of some type of other neurologic disorder. Difficulty recognizing or using familiar objects or people or sounds or smells. Okay? Loss of ability to plan, dysexecutive syndrome. So this is a somewhat different way to think about this. But I'm happy if you remember progressive, can't do what they used to, and it's their short-term memory that's impaired or problematic. And you're light years ahead of everybody else. All right, so what about these impairments? They have to be significant enough to affect one's ability to do their day-to-day activities, gradual in onset and continuing to decline. Now, the Alzheimer's type tends to be more gradual, but a stroke-related dementia, you'd have a history that would be consistent with these deficits occurring sometime in the proximity of the event that took place. It's not delirium. No, people talk about acute dementia. There really is no such thing as sudden onset dementia. People do become delirious. Delirium is a sudden onset of confusion, agitation, hallucination, aggression, paranoid thinking, delusional ideation, sleep-wake cycle reversal, and fluctuating sensorium. You can kind of bring them back to the planet, but they head back into the abnormality and the delirium that they have. Okay? Dementia patients are more likely to become delirious, in particular in hospital settings or illness. Patients who develop delirium have a greater probability of having a dementia that may not have been previously diagnosed. So there is some relationship between the two, but they are different illnesses or different problems. All right, so what goes on early? Because some of what I'm going to talk about today is really the next 30 years, not the last 30 years, which really what you're going to have to deal with is the next 30 years. Well, signs and symptoms that people really express early on are apathy, withdrawal from usual activities. I quit going to church because I didn't like the minister. Translation, they were getting lost driving to church. They couldn't remember their best friend's first name. It sounds right. It makes sense. They didn't like who was doing the sermons. But in fact, that was not the reality. They often exhibit depression earlier on because they are aware of, wow, I remember my relative or my friend, and they become concerned, I am getting a dementia. So these will be things that you may or may not key in on in some of your evaluations of elderly patients. They have difficulty recalling the names of events, and again, this expressive language dysfunction, word finding. They just can't quite seem to get it out. They'll tell you the words in their brain. They just can't get it out of their mouth. All right? Later symptoms, this is like the two people driving. They go through one red light, another red light, another red light, and the passenger says to the driver, you just ran 3 red lights. The driver says to the passenger, I thought you were driving. All right, come on, these jokes are not easy to come by, folks. I've been pre-screened already, okay? All right, disorientation, confusion, behavioral changes. This is a late stage difficulty speaking, swallowing, walking. Now, this shouldn't be too difficult to recognize. Man, this person's really got some problems as they get out into the middle and later stages. Okay? Now, the National Institutes of Aging has got some guidelines that they published, and they talked about it being considered a disease of 3 stages, and will show that, unfortunately, the pathology may begin 20, 30 years prior to the clinical manifestation. Now, that's a real concern, and for some reasons I'll talk about later on, about a disease that in fact has been percolating in your brain for quite a long time before it becomes clinically manifest. And then what do we really do about that? I don't know, if I'm 40 years old or 50 years old, do I want to do some sophisticated testing that tells me about a disease that I may have that I might not actually die from or might not become clinically manifest for 20, 25 years? This brings up a whole big ethical issue and some other issues about economics and healthcare. All right. This is an epidemic disease. Now, while we talk about 5 million Americans, 40 million worldwide, that's today. I believe in 2030 it's going to be about 60 to 70 million by 2050. And believe me, most of you will still be around. I'll be 104 or something like that. There'll be about 115 million people. There's some relationship to this, maybe partly a disease of affluenza, the disease of too much. Now, it's an age prevalent disease, not an age incident disease, meaning it occurs more frequently as people get older, but not because they get older. So the ICD-9 code for aging as a diagnosis, I'm not really quite sure if it exists. I do see lots of people who see their doctors and, well, they said I was getting older. That's what's wrong with me. I'm older. And then one said when their knee was very painful, the doctor said, well, you're 90 years old. And they said, you know, my other knee is the same age and it feels fine. All right, so aging is not a disease. It's a phenomena, okay? So if you're diagnosing people with aging, you got to really kind of ask yourself, I got to come up with a better answer than that. All right, 1 in 8 people over 65, half of those over age 85 have dementia. 1 in 5, now this is a bit scary because I'm only 62, so I could be one of these 5, I don't know. 20% of people with dementia, 1 in 5, are actually under the age of 65. That's a lot, 1 in 5. Now, when you're younger, you have more cognitive reserve, okay? You got more functional neurons hooking up. You're not really getting all that clinically impaired. But, in fact, some of them have very subtle signs and presentations and may be part of the preclinical syndrome of this disease. Now, again, the major risk factor, advancing age. Remember, it occurs more frequently, but not because you get older or everybody would get it. Well, the evaluation. You got to do a history, mental status screening. There's something called the, I think, Montreal Cognitive Assessment, MoCA. It's in the public domain. There's a geriatric depression screen, or Savage. It's in the public domain. It's 15 yes and no questions. There's activities of daily living. So you kind of done some standard mental status screening for orientation, recognition. Yeah, my brain's going already. Visual spatial reconstruction, mood, okay, and ability to do one's day-to-day tasks, all in the public domain that you're free and clear and don't have to pay anybody any rights for usage. There's a standard series of blood tests and a standard head imaging study. This is very cookbook stuff. Now, other things about PET imagery. So a CT or MR is a structural brain image. You know, what's the structure of your brain look like? Big, small, yellow, blue, full of Swiss cheese, whatever. Now, PET scan is actually a functional brain image. How well is your brain working based on its glucose uptake? And there's another sophisticated version where they're looking for amyloid. Now, all that's amyloid isn't Alzheimer's. So you got to kind of put all the pieces of the puzzle together. We are getting into some other more fancy things about combination of diagnostic markers. When you read your head imaging studies, they talk about lesions, abnormality, you know, stroke, no stroke. They don't talk about structural markers like, you know, your hippocampus, which is your short-term tape recorder, it looks a little smaller than I would expect based on your history and your age. So it's not necessarily abnormal, but it is a structural marker, not a structural lesion. So we're kind of expanding out some of the ways we're interpreting neurologic imaging studies to be a little more accurate in what we're trying to establish. But nothing will give you more mileage, and everybody hates doing histories and physical exams, me included. But the best clinicians I ever met were the ones who were able to really discern a good history and do a good basic physical exam. And that's where the beginning of the payback is in terms of your evaluation of patients. It isn't diagnosis by lab test or diagnosis by imaging study or diagnosis by specialty consultation. Okay? So combination of markers, hippocampal atrophy, I don't know, anybody want to get a spinal tap, look at their, you're shaking your heads, no, me neither, that doesn't sound like a lot of fun. But it's something that may be used out there in specific individuals if you're really having some difficulty, and the importance of that accurate a diagnosis needs to be determined. Well, what about genetics? You know, the environment is the window in which our genetics express themselves. So there is some genetic predisposition, and there actually is some genetic mutations in very small numbers of people that in fact are contributors to developing Alzheimer's type dementia. So every month there's new stuff that's out there. Apolipoprotein E is a genetic marker. There's actually 4 conformations. There's apolipoprotein 2, 3, and 4, so you can have 2, 2, 2, 3, 3, 4, 3, 3, 3, 4, and 4, 4. And it's believed that the homozygote pair of the 4s is somewhat greater at risk. The homozygote pairs of the 2s somewhat less greater risk. But I just read something yesterday that said not so much the conformation, but your apolipoprotein E level. Okay, so not the quality, what was my confirmation, but the quantity of apolipoprotein E that I have floating around my body, in fact, may also have some predictive value. All right, so neither necessary nor sufficient to get Alzheimer's disease, these at-risk or these protective conformations. They're doing tons of these genome-wide association studies, GWAS, for late onset Alzheimer's disease. Genetics actually may only account for about 1/3 of all the AD risk. The rest is dependent on other non-genetic factors. And I suspect some of this issue of affluenza, this disease of too much. Although, again, it is occurring, it's a worldwide epidemic. Lifestyle modification, physical conditioning, mental stimulation, stress management, healthy nutrition. You know, it's a somewhat simplistic, and you know, I'm not the healthiest person in the world. You can ask Dr. Strobel. You guys had some lectures with Dr. Strobel, the cardiologist? You can ask him about me. I give you my permission. He'll tell you what an unhealthy human specimen I am. Believe me. And he could probably do a whole lecture about me, and it'd only take 2 or 3 minutes. So if you get out early, that'd be good. All right, so again, you know, we are what we eat, we are what we breathe, we're poisoning the planet, sorry. You know, this is what makes America and us as a species so great. We like to go out, conquer, destroy, kill, take over, just because we can, not for any specific territorial imperative or any reason or any benefit. We're just a consumptive species that's out there. I think of that 4th of July movie, you know, where the aliens are out there and they're just going to come in and decimate the planet and go on to the next one. That's kind of what we're doing, but it's somewhat of a slower pace. All right, so what are the risks? This should look like metabolic syndrome, right? Diabetes, high blood pressure, hyperlipidemia, cardiovascular disease. I think I'm missing something in there. Maybe upwards of 2/3 of patients have a mixed pattern. They have some risk for the traditional Alzheimer's type, but they also have risk factors for vascular type. You know, the triggering mechanisms for all of this amyloid deposition and insoluble amyloid, and it's not really clear. We haven't quite gotten, I don't know, is it upstream far enough? And I'll show you something about what Alzheimer's actually said 2 to 3 years after his Sentinel paper came out that really kind of puts a lot of this together in terms of what we need to think about this. All right, well, there's plenty of stuff that supports a link between vascular disorders and Alzheimer's disease. And remember, there are vascular dementias in and of themselves, okay? So drugs that cross the blood-brain barrier may influence neurotransmitters involved in cognition, cerebral blood flow. Boy, we like to get people's blood pressures really low when they're 85 years old because we're going to preserve the myocardium. They can't function, they can't stand up without passing out, but man, their blood pressure sure looks good. We know about hypoxia causing problems with amyloid precursor, problems with potassium, increased inflammation for potassium's low. And we're seeing some weird things about medicines that are out there that, although they're used to treat certain diseases, may actually have some other effects regarding Alzheimer's type dementia, not just good blood sugar control or improved blood sugar control through the use of metformin, insulin sensitizers, and some other diabetic medications. So, does metformin actually promote neurogenesis and ameliorate neuronal insulin resistance? You know, the brain actually is an insulin-sensitive organ. Now, in deference to my wife, if you looked at one of her textbooks from 50 years ago, it kind of says, nah, insulin, the brain, no connection. But in fact, that is not true. What about angiotensin? It's a class of drug. We know that these receptor blockers reduce vasoconstriction. They may have other effects to improve synaptic plasticity and cerebral blood flow, and also insulin-regulated aminopeptidase. Increased activity of these c-Met receptors may improve cognition independent of lowering blood pressure effects or blood pressure lowering effects. I guess the point of this is, again, this next 30 years, if you had mentioned this 20 years ago or 10 years ago, people would have looked at you and you don't really know what you're talking about in terms of dementia. So, as I say, we're at a kind of a turning point in our knowledge and understanding and the next 30 years of how we will begin to address issues of dementia and how it's actually related to many other facets of our lives and our health and our environment. I kind of found all these cool slides. I'm not really sure what they mean, but this is just kind of showing the receptor blockers, okay, and the converting enzyme inhibitors, and how through this down scheme of angiotensin 3 and 4 and c-Met and IRAP, how in fact this drug or these classes of drugs may in fact have some benefit. Now, does this be an off-label indication to put all your Alzheimer's patients on this? All right, but you have someone who has some cognitive impairment, they've got some blood pressure issues. Well, this would be a fairly reasonable choice of a class of drug. Assuming the ACE doesn't give them a cough syndrome, you could do as an ARB, but these are some things that hopefully you will have a knowledge base of and consider this in your at-risk patients and how to continue to treat them. All right, now this is some other new stuff that kind of came out, and this is showing about the risk of anesthesia and surgery and dementia in seniors. Now, this has kind of been known. People over age 75 undergoing a heart bypass surgery, no problems with the surgery, had a somewhat greater risk of developing a post-pump bypass dementia syndrome, meaning within several weeks to a month or two after the surgery, families said, man, they are just not the same. I think we don't recognize a lot of the subtleties in post-operative patients for mental status abnormalities and confusions, and most of them recover. But I believe this is from the American Association of Anesthesiologists that came out in their national conference maybe 6-12 months ago that said, you know, there really is some greater risk. We have to be more cognizant of this elderly population, and particularly old, and some of the subtleties, even though the surgery went fine, the anesthesia was fine, but in fact this is a risk issue that families and patients need to be aware of. Now, this is another sad but emerging phenomena in the diagnosis of dementia, chronic traumatic encephalopathy. Football players. Now, are you guys all aware that the National Football League actually made a large payment to the Players Association to kind of suppress further controversy and further lawsuit? Now, do you know why they did that? Well, money, the almighty dollar. And they didn't want a big stink about all this. And I think there was something on the news yesterday about a guy named Ignacio, a football player. They tossed him out of the league. He was on a rant. All right, well, I mean, this isn't football in Europe, you know, where you're kicking the round ball around. This is football in America. These are the gladiators. This is the Coliseum. I love America. I mean, you know, that's what we're doing here. We're killing each other. And it's great for television and ratings and advertisers. Okay, so, although I did watch a soccer event the other day, they were burning the stadium down in Europe or something. They set the seats on fire. They're just years ahead of us. They're just more subtle about it. You know, they have more savoir-faire. You know, we just go out and shoot you. They're kind of a little more clever about it. We are human beings. We're all the same. Okay. So, CTE, National Football League. You know, it isn't just so much that. You guys are pretty young. I don't know how many have kids playing soccer or got kids at all. But I'm wondering, should that 8-year-old kid be doing a header with the soccer ball? Is that good for their brain? I kind of think not. The other group that you're going to see, unfortunately, is the military coming back from injury with improvised explosive device and shockwave trauma. It's not just your brain, it's your chest, all kinds of stuff. So this, unfortunately, is a sad and emerging phenomena that's out there regarding a cause of a dementia syndrome that sadly will increase in its frequency, and you're going to have to become more attuned to recognizing this. All right, so it really is a distinct form from other neuropathologic conditions. Now, you actually get this tau protein problem. We talked about athletes, contact sports, military personnel, repeated brain trauma. I actually think I diagnosed a case of this a couple weeks ago. I've seen a case before. He was a former football player. But this guy had been knocked out as a kid. He had been knocked out several times. He was in the military before IEDs, and he was in several plane crashes. And actually what shows up on the next slide is he presented actually more with a behavioral symptom and mood change as his presentation, as opposed to the cognitive functional episodic memory impairment dysexecutive syndrome. CTE is out there. This is something you will see, okay? You'll have to be a bit attuned to it. They tend to be a little bit younger. This isn't the 75-year-old. This probably tends to be the 55 to 65-year-old. And ask about contact sports when they were younger. All right, so what is our goal? To protect the healthy brain and develop disease-modifying strategies. You know, the ounce of prevention is worth a pound of cure. Your great-grandparents told you this. It's still true today. All right, so medicines right now are primarily symptomatic. They can slow progression. All right, so it's not that they're going to get better, but hopefully I'll be able to delay or maintain, your cognitive reserve. Medicines that clear amyloid. Unfortunately, there's been a few of them out there. They've never really clinically provided any specific benefit. Are we using them too late in the disease? Because I've got some other slides that will show what's really going on. Anti-tau treatment. What about anti-inflammatory drugs? This issue of inflammation is another piece of the puzzle that's messing up our brains. What about cholesterol-lowering drugs, statin drugs? Now, you got to put people on CoQ10, all right, when they're on a statin drug. Dr. Strobel will tell you this. Statin drugs reduce CoQ10 levels in your brain. It's an antioxidant. There is some suggestion that statin drugs may actually cause dementia, but in the aggregate, they actually help reduce the risk of dementia. All right, so these are things that we got to be aware of out there. Now, everybody's looking for the holy grail, okay? Everybody's looking for the serum dementia test or whatever. There is this thing called protein kinase R. It has a role in recognizing and signaling in viral infections. The activity is highly elevated in patients with AD. PCAR is phosphorylated in CSF, 300% higher in AD. Now, the interesting thing about this test, and for all of those of you who have epidemiology backgrounds, sensitivity and specificity, okay? So this is how I remember it. Sensitivity's got the N in it, all right? So that means the test is negative if you don't have the disease. Specificity, P, the test is positive if you do have the disease. Well, look at these sensitivity and specificity numbers. Those are really pretty unbelievable. Listen, standard tests may be like 20% sensitive, 80% specific, or you flip them around. Those are still good tests. This is rather outstanding in terms of the sensitivity and specificity of this test, if in fact it really is that good of a marker for looking at dementia syndromes. Oh, that's another one of those cool things. This looks like, I don't know, fettuccine with like sun-dried tomatoes maybe and some kind of blue oyster sauce on it or something. All right. Well, what if an individual looks normal? You know, like me. I kind of look normal. And nobody complains. Well, no, my wife complains. Is it reasonable to evaluate them for cognitive and functional concerns? Well, actually the answer is yes. Ignorance, delay in trying to establish some appropriate help for people really doesn't do anything except ultimately put it off and make it worse at the time. All right, so affected individuals are usually unaware of the severity of their symptoms. They appear normal in speech and affect. There's often a sentinel event. Something happens where they get lost driving in a familiar place, and they are a retired bus driver who's been in this city for 50 years doing that. Now, that's pretty sentinel, okay? Forget me in the checkbook because I never balanced it anyways, all right? Some medication mismanagement where they're really having problems, and this has been going on, I don't know, 6 months, a year, year and a half, and they're really messing things up. They're getting ripped off. It's a multi-billion-dollar a year industry in this country, fleecing seniors. It's also a new senior Olympic sport in Genesee County for children to fleece their parents. At least that's what I found in the community that I live. Social isolation and withdrawal, these are early findings. They have great explanations as to why they're not doing these things. But in fact, they are afraid and they're having impairments. Poor health habits, boredom, lack of exercise, poor diet, sleep disruption, obstructive sleep apnea is not good for your memory, and changes in personality and behavior. Okay? These are things that you're going to see. Well, there's a staging to all of this. What about mild cognitive impairment? You will start to see some people whose families and patients talk about, my short-term memory is not as good as it used to be. About the last 6 months, year, I'm doing everything I've always done, but I'm telling you, Doc, my memory is just not quite as good. All right? They may have some expressive language dysfunction. They may have some of these other changes that you can consider regarding cognitive impairment. They usually have an awareness of what's going on. Now, MCI does increase your risk. This is probably early dementia. Now, sometimes it's just isolated memory impairment. It's just short-term memory. Everything else is okay. Sometimes it does start to involve multiple domains, meaning they are having some subtleties in some of their functional capacity along with some short-term memory impairment. This probably is early dementia. Now, this kind of is I thought, a really cool-looking slide. But what this is showing you is a variety of things here, and I'm going to kind of try and make some sense out of this. All right, so this is kind of evolution of functional impairment, right? This is evolution of cognitive impairment. Here's your dementia, your MCI on the schema of things. Your time coordinates on the bottom. Now here's some of your preclinical phase, all of this stuff, and some of the studies that you can consider in terms of MRI, FDG, it's a PET scan, getting some spinal fluid, functional MRI. Functional MRI actually seems rather sensitive and specific, although I'm not really sure. There's lots of MRIs out there, but they're not really doing these functional MRIs. They actually stick you in the MRI and do some mental status screening and kind of look at your brain light up or not light up. And then here's what's happening with the tau protein and the A-beta insoluble 42 amino acid sequence. Now, here's actually onset, and you might not be diagnosing them until here, but look what's going on 20 to 30 years before they actually get diagnosed. Now, this is a very significant problem. Do you want to do some testing? Do you want to be diagnosed? Do you want to be out there 20 years before you actually have a clinical manifestation? Do you want to subject yourself? What is this going to do for you? I'm not diabetic. Maybe I'll go on metformin. I don't know. My cholesterol's not bad. Maybe I'll go on a statin drug. Now, before the Affordable Care Act, I would say, you'd have a pre-existing condition and you couldn't get health insurance. Now, it doesn't matter if you have a pre-existing condition. You can get health insurance. You can't get on the internet to buy it, but you can get it if you can actually get through the internet. I figured I'd get a mixed response to that one. All right. This is another complicated slide. I suppose the point of this is looking at tauopathies, problems with this tau protein, which is actually involved in other diseases, such as Parkinson's disease and multiple sclerosis. Now, you can see you got AD and the amyloid beta accumulation, and then tauopathies. But you notice they kind of start to merge down here. And although the amyloid cascade or the amyloid theory for 30 years has been the predominant thought as to Alzheimer's disease, actually there's an emerging growth, or there's an emerging concept about tau, in fact, maybe having more earlier pathologic influence than amyloid. Okay? So they are looking at anti-tau therapy. Shift in the cultural paradigm. All right? Heterogeneity. There's variation as people get older. All right? There's lots of modifiable risk factors. And if you look at this thing, it really applies to most of the diseases that we get in this country. The diseases of affluenza. We also get, that's also the environment, are polluting the environment too, okay, because of our lifestyles and the industrialization of America. Parkinson's disease, as an example, was not really described in old world literature like the Bible and the Quran and the Torah and things like that. Parkinson's disease really didn't start to emerge, I think, until the early 1800s. There is a significant association between environmental toxins and the evolution of Parkinson's disease. Now, you may remember 15, 20 years ago, maybe 15 years ago, some designer drugs in California had a byproduct called MPTP. And you got MPTP in your brain, you had Parkinson's disease 3 days later. So I believe James Parkinson is the physician who initially described the disease. But it's not an old world disease, it's literally a new world disease. Now, I'm sure there was Parkinson's disease in the old world, but not like we see it today. And the issue of the environment and what we're doing to ourselves is, I think, recapitulating itself on an ongoing basis through a variety of health problems that we have. So what did Alois Alzheimer say, who we've kind of started to describe and discuss his disease? So in 1906, August Dieter died. In 1907, someone wrote the paper, the Sentinel paper. And then in 1911, Alois said, there is then no tenable reason to consider these cases as caused by a specific disease process. So he's really talking about all these other things that go on that are part and parcel of this disease that was named after him and may not be a single unified entity. And he had a lot of insight, obviously, because he didn't have an electron microscope then. He had a light microscope. He didn't have all the other sophistication and things that we have now in terms of medical technology and science. But he must have had a lot of insight, because a couple of years later he says, you know, there's probably a lot of stuff going on, not just what I'm describing and seeing in this unfortunate woman who passed away.